together with problems that are going to occur. And I know for that test you had to have some basic interventions and basic treatments for those things, and those will be asked on these slides as well. So what I want to do first, you can type this out or write it on a piece of paper. I want you to sit back and just think about, what do I know about these three things, okay? Because I bet you could probably fill up your paper with a good chunk, and it's going to give you an idea as to what you need to focus on. So I want you to do like a column, type 1, type 2, and then I want you to put gestational diabetes. Yes, Amy?
Can you put the PowerPoint in Canvas, please?
Is it not on it?
It's a blank one, I guess. It doesn't hold.
Let me email you. I was having some problems this morning doing it, so I'm just going to email the class. I don't know if there was something with like the format of it. All right. Let's go here. I will make sure, I'm going to go through Canvas today to make sure all those other links work too. So sorry, you'll have to look at your email and pull it up that way. I'll give you a minute to do that. It's something like when classes go from like a different year to a different year, sometimes it's lost, I'm not sure why, but it's just some of the formatting. And iPads are different too, how you open it up. So as you open that up, make your 3 columns, type 1 diabetes, type 2, and your gestational. And I just want you to write down anything you know about it. Do you know the pathophys? Do you know risk factors? Do you know symptoms? Just anything you can think of. Did anyone watch the Oscars last night? I went to bed when all that happened, and I was like, God dang it, I watched for like 2 hours, it was kind of boring. Went to bed, and then I saw that Will Smith punch Chris Rock, I'm like, where the heck was I? I was like, I don't know if that was on, like a stage, kind of, I don't know. I just don't know why you would do that, but you'll have to Google it later if you didn't watch it. But, yeah. I think that, I mean, there's some theories out there that the Oscars have kind of gone down with like views. And people don't have cable either. So they thought it was maybe just a publicity stunt to obviously get people talking about it. So they'll watch the Oscars again. But I don't think Will Smith would have said that unless there was a lot of money involved.
He won like 2 seconds later too.
Yeah, that was pretty hard. I mean, he probably thought he was going to win too, but I mean, he's front row. I mean, for best actor. But all right, got a couple things. I would probably imagine that out of those 3 things, I'd be shocked if one of your papers in this room doesn't have something, at least one thing, if you can remember one thing on all of them. So with diabetes, we probably put this on the line of, how often are you going to see diabetic patient? Every single shift, every single shift. I'd probably be shocked even to say, have you ever done sliding scale insulin? That's pretty commonly done. If you haven't, it's not the end of the world. You will get one. But for those types of patients, we deal with this every single day. This is a lot of your boards. Like, this is a very high content area where, you know, it comes back to like the pathophysiology as we introduce it. In the fall with pharmacology, health assessment, we learn it here. And guess what? In the fall, when you do your obstetrics and gynecology course, you're gonna learn about gestational. It just never goes away. You're gonna learn with type 1 diabetes, I just want to see a couple points. We're not going to put everything on here, but what is something that probably, let's go back to pathophys, we have to understand about type 1 diabetes? No insulin, okay, that's very, generic, but in theory, yes, it's correct. We don't produce insulin. So what organ are we referring to? Okay, so this person's pancreas does not produce insulin. Then why, if we diagnose this earlier in life, then why can someone be 17 years old and live 17 years if the pancreas did not produce insulin? Why is that person not diagnosed right at birth? What's that? So there are other hormones that are going to help with sugars, but I'm talking like if they don't make insulin. Usually people they're not born with no insulin production, or their pancreas isn't 100% defective. There are cases where you have a kid that has a pancreatic problem. However, usually it happens in childhood where they get some type of stress, trigger, infection, autoimmune that destroys the pancreas. Or they're producing a little bit and getting by, but not enough to become symptomatic, or they have very minimal symptoms. So typically we see this diagnosed earlier, sometimes 4 years old, 5 years old, pretty common, and even into like some adolescent, young adult. I think we were in Parkston, I don't know which group it was, I think he was probably like 20 something, he got diagnosed with diabetes type 1 for the first time. And they were even arguing, is this type 1? Like how did he go 25 years without getting diagnosed? He was just kind of a rare case, okay? So it could happen. With type 1 diabetes, if you're not producing insulin, you're going to start to have symptoms, okay? And we'll kind of talk as we get through our slides as to what those symptoms are. Anything else that kind of puts type 1 and type 2 separate from each other?
Type 2 is not modifiable.
Say that again?
Like, is it modifiable?
Okay, so maybe potentially reversible. So I don't know if I like the word reversible, but I like the word resistant, because resistance can potentially sometimes be reversible. Now, you might have a case where someone gets diagnosed with type 2 diabetes at 50 years old, someone that's a little bit older, and they are morbidly obese. They have no exercise, they have all the risk factors. However, they make this transformational, they lose 150 pounds, they start to exercise. Theoretically, yes, you could reverse this, but it's not 100% effective. So do we say in every patient it's reversible? Not necessarily, but we say you have a better chance of managing this and potentially getting off of insulin or getting off of medication if you get down to a healthier BMI, okay? So reversible in theory, yes, technically you can get off your meds, which is that for people reversible? That in their brain, they're like, if I get off meds, it's good, right? But they're always gonna be probably considered like pre-diabetic or have an underlying risk factor for it, okay? So resistance, meaning that your insulin is produced, okay? You have insulin production. Your pancreas still does it, but what's in the way? Fat, adipose tissue, right? So if you lose the fat, you could produce more insulin from that pancreas. The pancreas still works, it's just blocked. It's just blocked from whatever's in the way, which is usually your adipose tissue, okay? Let's talk about gestational diabetes. Who gets it? Okay, so obviously pregnant. Does it go away? Okay, yes, it can linger after for a little bit. However, it usually, if the baby is gone, it does go away. What does it put you at high risk for if you have gestational diabetes? I'm talking about after. Let's say after you're done being pregnant, your diabetes or gestational diabetes goes away, or theoretically your sugars become normal again. It puts you at high risk for type 2 diabetes sometime in your lifetime. Doesn't mean 100% you're going to get type 2 diabetes. However, it shows that if you were actually gestational diabetic, you have a higher risk factor later. Okay? Now, do some people have no risk factors, no genetic predisposition, and they get gestational diabetes? Yes. Okay? It has to do with the stress of the fetus, how their body regulates those hormones, and how that body's responding to it. So they do have a higher risk later. However, they could never have a diagnosis again of gestational diabetes. What about pregnancy to pregnancy? If one has a gestational diabetic pregnancy, the next time that lady gets pregnant, will she get it again? What do you guys think? Or what if the first one, she didn't have it, but the second one she did? Like, does that happen? Yeah, it does happen. It is based on the pregnancy. Now, there is a higher risk if you've had it with your first one, you will have it with your second and third, fourth consecutively, but it's not always the case. You can potentially have it or not, okay? All right, so now, based on what you have on your list, we're gonna go through and see what comes up and see if you can identify. So we have to know inside of the pancreas what your pancreas does. There's different cells that are gonna be the primary mechanism of how your body regulates your blood sugars. So if you remember from pathophys, there's types of cells in there. What is the circle of cells called that all these are located in? Remember what that was called? It was basically the location on your pancreas that has your alpha, beta, and delta cells. And there's like a little circle that basically has these cells in there. Okay. See if I can do the first letter. Does anything come back? I'll start with this. It's 3 words. Islets of Langerhans. I don't know if I'm spelling it right. But islets of Langerhans. You're probably like, what the heck? But really, this cluster of cells is where all of these hormones are being secreted from. So it's a pretty significant area. So if that part of your pancreas is being destructed or problematic, you're going to have problems with all these issues. And I always bring this up because it is true that your body's constantly trying to maintain homeostasis. You're trying to maintain this equality where you're not too high with blood sugars and not too low. We've noticed this with every system, that your body's trying to go back and forth to make sure that you don't have issues. This is why people that don't have diabetes can go have a steak dinner with all the trimmings and sugar and all this stuff. Your blood sugar is not 500. Your blood sugar might be 180, okay? But if you're diabetic and you don't have these functioning cells, you can't maintain that neutrality, okay? So alpha cells inside of that islet cell is where the glucagon is secreted. So glucagon, we've all probably saw this, and some type of test question, or we know kind of the function. What is glucagon? Sugar. That's all it is, it's sugar. You can get synthetic sugar like glucagon. Synthetic means that we made it. Or how else can we obtain sugar? We eat it, right? So it's when we become low with our blood sugar, we eat sugar, and hopefully you'll have insulin that'll let it in the cell, okay? Beta cells is where we get our insulin. So if you have a destruction of those beta cells, you typically are going to have that type 1 diabetes diagnosis. So pathophysiologically, type 1 diabetes is a destruction of beta cells within the islets of Langerhans. That is your pathophys. If you have that destruction, you have a diagnosis of type 1 diabetes. All right, delta cells, I really don't talk much for this test, only because it's more related to kind of the exocrine factor of digestion. It has a lot to do with how we digest foods, how we take up the sugar from our foods, but I don't really ask a lot on your test about delta cells. Okay, it's more about the beta and the alpha cells inside of there. Okay. When we start talking about GI, we'll talk more about some statin and some of that delta cell inside of the pancreas. Okay, so in your body, every cell, it's in your toes, in your kidneys, in your heart, doesn't matter, you have to have insulin to let the sugar in. So this is why when we talked about DKA from last week, if you have DKA, you could be eating all you want, right? Polyphagia, all that you want, but why can't that sugar get into your cell? You don't produce any insulin. You have to have it. It's the key to the cell. There are 2 organs in your body that do not need insulin to get blood sugar in, or the sugar inside of the cell. You know what those 2 organs are? They can function with very little to no insulin. You're like, you want to say the wrong answer? There are 2.
Liver.
Liver's 1. Brain. And this is why, if you're starting to get cognitive differences because of blood sugar alterations, it's bad. Because it's kind of the last organ that can deal with a lot, but as soon as you start to get cognitively unable, or you're becoming more lethargic, or issues with cognition, that is probably problematic more so that you're not getting that sugar inside of the cell, okay? It can work with some, so you don't need really that insulin to do that. It's the last kind of organ that if it fails, it's in bad shape, okay? So we need that insulin. It is the key to get into the cells inside of the body. So you're constantly trying to get that insulin in so the sugar can follow. Okay, so type 1 diabetes, we'll start with this one. We already talked about how it is a pancreas problem, but we just learned one new factor. It's a destruction of which cells? Beta cells. Okay, do you remember back from patho, our guy Eric? Eric Storms was his name, and I did an interview with him, okay? So when was his, if you can remember, it's been a while, so I'll refresh your memory. I did put that, that video on modules. It's not gonna be part of an assignment or anything, just if you would like to review it, you could. With Eric, when was his diagnosis done? Like what age was he? Remember? He was in high school, right? I don't know if he was like 16, somewhere in that range. But he wasn't quite 18, he wasn't 14, somewhere in that range. But he was high school, and I asked him I was trying to get information out of him about risk factors. I don't know if you remember me asking questions, and at one point he was kind of like, what are you trying to ask me? Like, what do you want to know? But what kind of risk factors did maybe he have? There wasn't, right? With type 2 diabetes, we could be like, yeah, you're overweight, and your parents had it, and you have this lifestyle. But with him, I asked him, did anyone in your family have type 1 diabetes? No. Did you have any issues, like as a kid? Did you have cancer, any infections, or any types of exposures? And really, we couldn't find anything. So what is the term we use for someone that doesn't really have the cliche or any risk factor that said, yep, you have it? It's idiopathic. We don't know why. This can be very frustrating on families, especially younger kids. So if a mom or dad comes in with their child and they're kind of having those symptoms, and the child that's 4, which in that dynamic, think about diagnosing a child with type 1 diabetes, the lifestyle changes that have to occur. What kind of emotional stress is going to be on the parents? What did we do to cause this? Why did this happen, right? You guys will have an advantage because you're in healthcare. So you understand the pathophys of what happened. Although frustrating, you understand. Now put someone that has a 1st grade reading level who doesn't have finances to even purchase insulin, if that is the case, and a 4-year-old who maybe is developmentally delayed on top of that, okay? So there's a lot of factors that go with this diagnosis that is very hard for people to absorb and understand, okay? But type 1, there may not be a reason. They have shown that if they have other autoimmune problems, there is a higher risk factor. However, it's still not like 80%. Just because you have lupus or something like autoimmune, you're not gonna have a 100% chance of getting type 1 diabetes. What about families? What if dad, so let's say Eric, because Eric has type 1 diabetes, he's got 3 boys. What are the chances his sons get it? It's also not astronomically high. It's about 5%, okay? It's a chance. So are they gonna be watching those boys to make sure that they're not having symptoms? Absolutely. But it's not gonna be like, once you get this diagnosis, your kids 100% get it. It's about 5, sometimes they'll say 10%, but usually 5%, okay? So what are symptoms? So if we remember from when Eric came in, what were some of his symptoms that he had? And I'm gonna put this under type 1 and type 2 because high blood sugar is basically what happens with both of these problems. It doesn't matter if you have a defection of that beta cell or you have a resistance. You're still gonna exhibit the same signs and symptoms whether your blood sugar is 600 from type 1 or 600 from type 2. So the 3 Ps, and the whole reason you have this is because of hyperglycemia. So what is normal blood sugar? 70 to 100. That's what I'm going to keep with because that is the national guidelines that the American Diabetic Association is going to use. You could see in some facilities 70 to 110, but is anybody jumping out of their seat at 110? No, okay? I want you to use 70 to 100 when it comes to diagnosing them on this test, okay? And that's a fasting blood sugar. That's not like you had, a lunch or breakfast and then you took it. That's when you do not eat for a few hours before, okay? So with type 1 diabetes, they're gonna exhibit these signs of 3 Ps, which will come on the next few slides, but really that blood sugar is the problem. That's why they're having these symptoms, is because their sugars become high, the insulin is not produced to get it in the cell, so if we put, I'll use your example here, Maddie, but if this is our body, and we have this half full, and you dump a bunch of sugar in there, it's gonna get very concentrated, right? So if you get a bunch of sugar in there, it's gonna cause it to become more it kind of dumps into your kidneys. And that's why one of these P's, which is polyuria, is occurring. And the reason why is because of osmotic diuresis, osmosis, okay? So with this diagnosis, you could potentially, if you don't have sugar that can get into the cell, what does your body start to do? It starts to say, okay, I have 3 ways that I can get energy. One of them is carbs. That isn't going to work. What's our other 2? Fat and muscle. Muscles always last because your body does not want to pull energy from muscle because that is like how your body functions. So it's going to go to fat. Has anyone ever done like the Atkins or low carb diet? Anyone ever done it? You don't have to admit it. But if you have, what's the point of that diet? It's very similar to DKA. You remove all the carbs from your diet. Not all, you might get 25 to 50 grams, which is not very much. And your body's going to go, I have no carbs to take my energy from. I'm going to take it from where? Fat. And that's why they lose so much weight so fast, because your body uses carbs instantly for energy. That's why when you go work out, if you just had a high carb meal, it's actually going to take from the carbs and not from your fat. Okay? So these people that now they have no carb intake, and then all of a sudden their fat has to be taken down for energy, your body's going to go, oh, I don't really like to break down fat to high amounts, so it's going to start showing ketones in their urine, which ketones would be what kind of sign? Ketosis, right? It's the breakdown of fat. Let's say you get a person that's very malnourished. They don't have fat. So now if they don't have carbs, they have little fat on their body, now it's going to take it from muscles. And typically, you will see type 1 diabetics, they lose weight, okay? So they're losing weight, but somehow they're eating like a college or high school boy would eat. He said, he goes, I ate all the time, but he was losing weight. And he thought his reason was, I was in wrestling, I was cutting, and I was doing a lot of stuff for exercise, so I just thought, oh, it's normal. But a college or high school boy that is actively eating probably 5,000 calories, honestly, they eat a lot of food, and losing 10 to 15 pounds in a couple months, something's not right here. Even if you are having activity, 10 to 15 pounds is a lot. They should probably be maintaining their weight, maybe not gaining, but maintaining with the exercise that they're doing. But the losing of the weight is fat and muscle. Okay? So they're losing that component inside of their body. Can type 2 diabetics go into ketosis? What do you guys think? Ketosis. I need the steps. I'm going to keep it over there because I need some steps. Ketosis. So remember DKA, what does that stand for? Diabetic ketoacidosis. It's a ketosis. You can go to ketosis if you have a starvation diet, if you have low carb diet, or if you do not have the insulin to get to your cells. Now 90% of ketosis is going to occur in type 1. There are some cases where a type 2 diabetic could go into a slight ketosis, and there's only one way that this could occur. Their diabetes is so bad, the resistance is so bad, so much truncal obesity, so much adipose tissue, it blocks the entire pancreas. So these people that are type 2 diabetics typically only get what kind of medication? Oral, right? We typically don't give them insulin. Can sometimes they get insulin if it's that bad? Yes, because their pancreas becomes so blocked with adipose tissue. Okay? So this is extreme cases. This isn't the norm, but it's extreme cases where the person goes, I'm type 2 diabetic, I'm not changing anything, I'm just gonna take this little pill. It's fine and dandy until you gain more weight, more issues, and now that pill doesn't work anymore because you just don't have the mechanism to help your pancreas. So that's where they might become diabetic, okay, or diabetic, more insulin dependent. And they could have a trace. If you ever look at a UA, you guys have started to go to the hospital, looked inside of the UAs, it'll say a trace of ketones. What is the most we can have in a UA? It'll say like plus signs. 3 is the most. You got 3 plus, 2 plus, 1 plus, trace. So with your ketosis, you're going to see more of the 1, 2, 3. With your type 2 diabetics, you might see a trace of ketones, meaning that this person still makes a little insulin, but it's not very good. So we're starting to see a little ketosis inside of their body. So if you've ever been on a low carb diet, anyone ever had it? I'm going to bring you up, Max. I know you're doing a low carb diet.
I have before.
Yep, you have before. What's your breath smell like? Did you ever have any issues? It's nice and fruity, okay? I did a low carb diet one time, and it takes about 4 or 5 days for your body to get into ketosis. But my husband's like, your breath reeks. It's horrible. It's horrible, horrible, horrible. And it wasn't like a bad smell. It's like a fruity, yucky smell. And I go, good. So it smells supposed to, I'm in ketosis. Okay. So that's how the person knows. You can test your urine. People that are in these diets will test their urine. What do they test for? Ketones. Is this a good thing? No, this is, and after you start to realize this is not a very good thing. Now, low carb diets in some degree, yes, but to a point where your body's in ketosis, I don't know. Like that's getting a little bit kind of extreme, because if you were in DKA all the time, your kidneys would start to shut down. And a lot of times these people on these diets will have kidney failure, even in extreme cases, where they're in ketosis for like weeks to months, and it could become problematic. So some of those diets will say go into ketosis for 2 weeks, and then have a week where you're not in ketosis. So it's not all the time, kind of thing. Okay? Okay, so what I want you to do is I want you to go through these symptoms, and I want you to think about the pathophysiology. Because remember, we can memorize these, but I want you to explain, why does polyuria occur? Why does polydipsia occur? Why does polyphagia occur? Why does weight loss occur? I thought the diabetics gain weight. Why is that a problem with weight loss? And then why are they fatigued? Okay, so I want you just to think in your brain, what is the pathophys behind those symptoms? So go ahead and jot them down. Hopefully you're listening. Shouldn't be too hard. Anyone do the Wordle today? I'm gonna get you guys all playing Wordle. Come on. I was up asking midnight last night, and I did it at like 12:05 because it starts over at midnight. I was like, I'm gonna do the Wordle. You probably do glycosuria, but it's pretty obvious why the sugar is inside of the urine. So on this test, I'm gonna give you like a UA, a urine analysis, and you'll have to look at it and see what looks concerning. Because we talk about kidney failure with this test, we talk about diabetes, dehydration, and there's a lot of parts of the urine analysis that I think are very relevant to know for this test. So I'll kind of keep track as we go, but you'll know kind of which areas to look for and what they mean. So we've already talked about ketones, what those mean. Now we'll talk about glucose. Okay. So are there any symptoms on this slide that are also consistent with type 2 diabetes? It's not specific just for type 1. Although it says type 1 up there, I see that. But if you think about the pathophys, it would make sense that type 2 would have it as well. Could you have glycosuria inside the glucose in the urine with type 2 diabetes? Yes. Okay, so that's true. I'm gonna write that, but yes, that's true. The 3 Ps, yes, you could have that. Now polyphagia, I will say that you have less of that with type 2 diabetes, because why? They produce a little insulin, so they are able to get some of the sugar within their cells. Weight loss, related to muscle and fat breakdown. That's why they lose weight. Even type 2 diabetics, if they are starting to get more resistant, they might say, I lost 10 pounds, and they're a bigger person. I lost 10 pounds this month, I didn't do anything different. That's kind of an idea to say, let we gotta investigate further. Why are you losing weight without trying? Nobody loses weight without trying unless you're stressed to the max, okay? But for the most part, you have to be doing something to lose weight, okay? Malaise or fatigue, malaise is fancy word for fatigue, but why would you feel tired? Do you ever you're studying and you're starving, you can't focus? You almost get tired, and once you eat something, you kind of perk up. Maybe not a steak dinner, but you eat a little something and you perk up a little bit, your sugars might be kind of out of whack too. But when they break down this muscle and this fat too, you do become more fatigued as well. And just the state of having that sugar imbalance. Okay? So those things could technically happen with type 2 diabetics also. So I don't want you just to say these are only type 1 diabetic. This is why I include them for kind of both here. So what is the pathophys behind polyuria? Really, 2 words that you should use. Osmotic diuresis. And we have to know that osmosis, that concentration that's going to move, or the fluid that's going to move from that lower to higher concentration is going to try to be equal. That's why it dumps inside of the kidneys. So your bloodstream has a very high sugar content and it kind of dumps into the kidneys. So when they pee, how much are they peeing? It's a lot, every hour they're going to the bathroom, or they're excessively getting rid of a lot of fluid, okay? Polydipsia, they're thirsty because of dehydration. If your body normally pees or urinates 3 liters a day, written in 2, and now it's doing 5 to 6 and you're not changing your water intake, you're gonna get dry, you're gonna get dehydrated. So that's why when we talked about in metabolic acidosis with DKA, they needed insulin and fluids. Their fluids is because they were having so much diuresis, urinating, and it was causing them to become dehydrated. Okay? And then the polyphagia. There is no insulin, so therefore the glucose, or the glucagon, cannot enter the cells to be used. So they eat. I always think of this guy, because I don't know if he's still out there, but he was a younger kid, 19, 20 years old. Every time he comes to the hospital, he'd have DKA, sugars in the 1700s. You had to be NPO, nothing by mouth, on an insulin drip. You cannot eat. Okay, why can you not eat? Your blood sugar is going to get increased, right? And now that we're giving you IV insulin to be able to take it in, we don't want your sugar to go increased. So these patients are starving on this insulin drip because they potentially are not getting their nutrients, and they eat. And so the time that they get to eat the first time, you have to be very careful, once you get off this insulin drip, because they're starving and they just want to eat 10,000 calories at once, and you have to be careful because it could alter that. So any type of insulin drip that they give through an IV, you should not be eating, it should be NPO. Okay? Polyphagia could occur from that lack of insulin. So those are the 3 P's. Type 1 diabetics, the common medication metformin, can they receive it? No, oral medications for diabetes cannot be given to type 1 diabetes. I'm going to say it again. Oral diabetic medications like metformin cannot be given to type 1 diabetics because there are different ways that those medications work, and they have to have a functioning pancreas that secretes insulin in order for them to work, and they cannot do that. They do not have that function. So type 2 diabetics are the only ones that can take that oral medication. Okay, so here's type 2, and we look at this as a non-insulin dependent. However, in severe cases, yes, you will see type 2 diabetics with insulin. When is another time that a type 2 diabetic might be put on a sliding scale insulin for a couple days? Surgery patients or hospitalized, right? So what has to happen with a type 2 diabetic that is always on metformin, they take it every single day, they go to have a knee surgery, and they're in the hospital for 3 days, and you're giving sliding scale insulin the first 24 to 48 hours or even before. How do we tell them that they're, this is not going to happen after surgery, or this is not going to happen when they go home? Because they're going to say, am I going to be on this all the time? The answer is no, but why do we have to put them on insulin? Why can't they just put metformin right after surgery? It takes a little bit too long, first of all, to get in your system, and if it's a day where you're not regulating it, it could cause problems. But surgery adds a lot of stress on your body. So when you have stress, what hormone is being released? Cortisol, which does what to our sugars? Increases it. So rarely we're gonna see some high sugars during surgery, even if they're NPO. We always tell patients be NPO after midnight, but sometimes we'll say we need to check your blood sugar because even if it's high, we still might give you insulin, okay? So we have to maintain that sugar of 70 to 100, that's our goal, but we don't want them to be too low, we don't want them to be too high. During surgery, will diabetic patients have more blood sugar checks? Yes, because we do not want them to become too high or become too low during surgery. One of the things when someone's having a code, remember, I don't know if I talked about this with everyone, but it's called the H's and T's. And basically, if you Google this, it's a list of things that happen during a code that if you have a problem with the patient that they code and you're not sure why, you should go through this list and rule them out to make sure that's not the reason. Guess which one of the H's are? Hypoglycemia. So blood sugar that's low. Could you code from a blood sugar of 5, 10? Yeah, you could. So always make sure we look at those blood sugars. Okay, we already talked about the pathophase. So who does this normally affect? So there's something called metabolic syndrome. I think I've talked about it before. But basically, they have these risk factors, and the probability of having a diabetic type 2 diabetes diagnosis in their lifetime is very high if they have these risk factors. Can you think of any? So metabolic syndrome is what the actual syndrome is called. You might hear people say they have metabolic syndrome. You see that in your histories. Well, what does that mean? Think about their weight. High BMI, or in other terms, obesity, right? Obesity. So we always talk about obesity being greater than 30, right? 30 high is obesity. It's a class 1. We have different classes of obesity in America. So class 1 is 30 to 35, class 2 is 35 to 40, and class over 40 is class 3. So you have different levels, because what if somebody was 30.2 compared to 50? Quite the difference, right? So they're still classified as obesity. That's quite a difference. So they kind of do a different range. Okay? So they have a increased risk because of obesity. Also, hypertension. Okay? So obesity, hypertension. One more thing that would put you at high risk for diabetes. They kind of go hand in hand. Another thing with your cardiac. Think of statins. High cholesterol. It's like family. If you have one, you're probably going to have the other at some point in your life. Because they just go so closely together. So when you have high blood pressure, you know, typically high blood pressure, yes, genetic in nature sometimes, but also lifestyle. Are you eating a high sodium diet, high calorie, high fat, right? It's hardly ever the time where you get a high salt food that doesn't also have high fat, right? It's pretty uncommon. Fried foods, for example, you know, you're gonna have that high sodium and high fat. So when people have obesity, they tend to have the environmental lifestyle of high sodium, high fat, high cholesterol. And once they have one, it's pretty common that they have the other. So once this person gets diagnosed with high cholesterol, high blood pressure, and has obesity, it's not going to be too long before a diabetic diagnosis is occurring too. Okay? But what do we notice about these things? If we don't have like our our genetic factor, can we get rid of all these? Yes, we really can. So that's why we put so much emphasis on diet and exercise in your guys' age and early ages of life, so that we can prevent this. What's the number one killer? Cardiovascular disease. That's pretty broad, because cardiovascular disease really is composed of those things: hypertension, hyperlipidemia, and obesity. So again, these are things that might increase that risk. What kind of medications increase blood sugar? There's one that we give that can increase blood sugars, and we have to be very careful in diabetics to not just give this freely, because it could make their blood sugars increase drastically. Steroids, corticosteroids. So that's another reason too in the hospital that patients that are on sliding scale insulin, maybe the physician put them on that because they're on steroids that they never usually get. How much could steroids realistically increase blood sugar? So let's say they run 100 to 150. That's just what they run at home. If we give IV solumedrol or IV methylprednisone every 6 hours, it could go up 200 points. A lot. It is very drastically high. So that's kind of the critical thinking that should occur, that if you're on the hospital and you have a diabetic that has a sugar of 300, you need to step back before calling the doctor and say, why is it high? Is it high because they ate too much for breakfast? Did they accidentally get the regular plate instead of the diabetic diet? Do they have an infection? Do they have steroids on? These are all things you're looking for to say, does this person's blood sugar match what's going on? Okay, so those are things that you'd want to look at for the medications. So this is kind of sad. I always bring this up every year because I think it's just, I guess it's just unfortunate that as society has kind of developed here, we used to say that type 2 diabetic, or diagnosis, was middle age to older age. Because really, it takes a lifetime of environmental things like diet, exercise to cause type 2 diabetes. But what are we finding now? You can get type 2 diabetes in your teens, okay? We've all seen children who are overweight, and it's actually becoming earlier and earlier and earlier. We have growth and development charts, like their BMI charts. We do this at birth, you guys. We look at their growth and development, and we always tell patients that we're trying to stay on this curve. We want to make sure that you're growing and developing. But what has society said? When you are on this curve, you're on the 99th percentile. Let's just say for weight. What does that mean to the public that has no medical background? Heck yeah, that's like almost 100. I'm doing great. But where do we want kids to fall? What is the growth chart looking at? Your average, right? Compared to other kids or in this society. So if you lined up 100 kids and you're at 99, you're fatter than 98 of them. That's what that means. So if you're at 50, you are somewhere in the middle, which is where you realistically want to be, okay? So yes, we're looking at development, making sure you're growing, making sure you're maintaining, but we need to make sure we educate parents that if they're 2, it's a little different. But if you're on that 99 percentile ever since birth, 2 years old, 4 years old, 10 years old, what is that saying about your weight? You are overweight. That's just another way of saying you're overweight. But sometimes as kids, you get a lot of breast milk, you're not gonna diet a little child. That's not what you're gonna do. However, if they're always on that 99 percentile, even at 4 or 5 years old, what is something educationally wise we can do for the parents? Let's find ways to be active, right? We would never put a 4-year-old on a diet. However, giving alternative choices besides sugar and junk food, right? Making sure that we're giving a plethora of nice fruits and vegetables, maintaining, normal milk, that's a big one. Little kids love milk. They might drink 12 glasses a day. Is that good? No, it's fat. There's a lot of fat, a lot of calories in milk. A couple glasses is fine. 2 to 3 glasses is where you want to be. Okay, so some of those things are just making tweaks to the parents' lifestyle and making sure that they're offering them things other than just junk food. Okay, but usually that age is usually now becoming lower and lower. So I actually did not know this. I'm doing some peds rotations right now. They actually test when they're now a teenager their lipid levels at 13 years old, and I just thought that was just crazy. I'm like, what? They're just doing this on every single 13-year-old that comes in for lipid levels because they've just seen so much increase in metabolic syndrome earlier and earlier to the point now they're screening for it at 13, 14 years old. Okay, so they have to look at those. If the kid is obese at 5, 10, 12 years old, they're going to test for it earlier because they're trying to prevent major things down the line from occurring. So what does the American Heart Association recommend for exercise in children? Because it's different than adults. So children would be 18 and under. We've always been told for adults, 5 days a week, 30 minutes a day, right? So those are what is the recommendation. What about kids? They want an hour, they say most days of the week, which usually in my opinion means 6 days a week, right? They might get 1 day off. But truthfully, little kids, I shouldn't say all little kids, but most kids are more energetic, right? And so if you instill that mentality earlier, they're gonna have more positive outlooks on exercise. What are some outlooks on exercise as an adult? This sucks, right? It shouldn't be forced. It shouldn't be something that you don't enjoy. You should find something you like, but instill that in kids too. Don't ever force them to do an exercise, because then they're just gonna hate exercise, right? Find something that they do like. Other risk factors. If family members have it, there is a higher risk factor, more so at type 2 diabetes rather than type 1. So if you think about if mom or dad had a type 2 diabetes diagnosis, why would their son or daughter have a higher risk factor than, let's say, type 1? Yes, so look at metabolic syndrome there. If that's the risk factor for type 2, and if mom and dad eat like crap, don't work out, watch TV all day, don't do anything lifestyle-wise, what are the chances this child's gonna do the same? Pretty likely, okay? Because they look up to their parents, and a 2-year-old's not gonna say, you know what, my BMI, 99 percentile, I better do some running, mom and dad. You're not doing it, so I better go do it on my own. So they lead by example. So the cycle continues, right? So through generations, we can't change society unless it starts with parents and goes on down, right? So that's why the mentality has to start at the beginning and go through, okay? Lead by example. All right, so then let's go down to race and ethnicity. So what races or ethnicities have a higher risk factor for diabetes type 2? There's usually 2 that are on the list here, maybe 3. African American, right? They usually have the highest for hypertension, diabetes, obesity. Native Americans is another one, and Hispanics. Okay, those are our 3 top ones. If I were to put them in order, I would do African American, Native American, Hispanic. Okay. I was talking to my friend that is a nurse practitioner in Omaha, and she had a guy from Guatemala come in, and we haven't talked much about hemoglobin A1C. But what is this? Do we know what that is? The guy she saw was Hispanic. He was, well, I guess Guatemalan, but still, no English speaking, has never saw a doctor in his life. So what is this lab that they measured on him? And it was the highest I've ever heard of in my life. It basically, over the last 3 months, it takes your daily average blood sugar. Okay, so 3 months time, I call it the lie detector for diabetes. Why do I call it that? Because a patient could come in, not have diabetes, they don't know they have anything. Nobody's checking their blood sugars, right? But if I do this test over 3 months, it's gonna tell me your daily average. So if one day it was 400 and the next day it was 200, your daily average is 300. Okay, it does the average for those 3 months. So normal, we wanna see between 4 and 6%. His was 18. And I know that may not mean a lot. There are charts that show you, it probably is even off the charts. A1C. I looked it up at one point, but I want to tell you right. You can kind of see here, that's 10. Okay, so this shows you, it even goes to 10%, which is still, anything over 10 is just ridiculously high. It's so high. If your estimated blood sugar was 240 every single day, it'd be at 10%. So what is, just doing kind of basic math here, what is his daily sugars average? Like 350, 400, right? If you just double that, because essentially 18% is almost double 10%. Every day,